All right, chapter 24. This used to be two different chapters, the hematologic and the neoplastic or the oncology chapters, and they've combined them into one because they both have to do really with cellular level stuff, bone marrow, um, components of the CBC. So they're very similar. So functions of the hematologic system. Of course, you got your RBCs, your white blood cells, your platelets. Any disruption in production or size or structure of these can result in a hematologic issue or disease process. Your RBCs are responsible for transporting oxygen, okay? So if there's anything that affects RBCs, like if there's not enough iron to produce hemoglobin, then that results in oxygen deprivation, etc. So they're kind of all tied together. Your platelets, of course, are responsible for your clotting, and your WBCs, there's all kinds of different WBCs, white blood cells. When you're looking at a CBC and you have a differential, your white blood count may be elevated, but it depends on which type of white blood cell is elevated as to whether it's a viral process or a bacterial process or an allergic process. So that's the differential. So when you have your white blood cells and then you have your different, like your eosinophils, your neutrophils, your basophils, those are the differential. When you hear a CBC with diff, that's what that means. All right, CBC with diff. Hey, there you go. Again, it'll tell you your red blood cells, it'll tell you your platelets, it'll tell you your white blood cells, and it'll also tell you the differential, which white blood cells are elevated. Reticulocyte count, you're going to see that drawn with sickle cell disease. Blood type and cross. With any of the anemias, you're probably going to see blood transfusions. With the leukemias, you're probably going to see you possibly could see some blood transfusions. So you'll hear that referenced a lot in this chapter. Clotting studies, if you have issues with hemophilia, clotting studies are important. Coags, again, same thing. Iron and lead levels, iron deficiency, lead poisoning, those are both part of this module. All right, some health history. You want to get a good birth history, okay? You want to get a good diet history. You want to get a good social history, as in where do they live? Do they live in an older house? Because you have to start to think about things like lead poisoning if the symptoms are there. Oh, one more thing on that one. Recent illness, okay? Real important because a lot of things are autoimmune or they idiopathic. They don't really know what causes them, but they could be autoimmune in that we just had a viral illness and now our body is attacking another system because of that recent illness. So that's real important to know as well. All right, nursing diagnosis that might be related to a child with a hematologic disorder: fatigue, especially with anemia, pain, sickle cell. It can be very painful. Impaired physical mobility because of, the lack of oxygen to the extremities or to the tissues. Anxiety, of course. All right, CBC, talking about a CBC. These are your parts. And we talked about the RBC count, the hemoglobin and hematocrit. You'll hear H and H. Those are, we always want to know what the H and H is. That might indicate that we need a blood transfusion if the hemoglobin's too low. When you do your RBC indices, that is looking at different types of anemia. And to tell you the truth, we're not going to get into very much detail on the different types of anemia. We are going to talk about iron-deficiency anemia because it's the most common, and sickle cell anemia. but the other ones, there's probably, well, I don't know, 50 different types, no, not quite that many, but different types of anemia depending on which of the RBC indices is affected. So we're just going to touch on those two. White blood cell count we talked about. All right, here's your normal, and again, these vary from facility to facility, so don't think that these are going to apply for your whole nursing career, okay? This is in pediatrics, this is what we're looking at. WBCs are listed there. You see in the infant stages, the WBCs can be a little bit higher and be normal, okay? As you get closer to as you get older, you get closer to the adult levels and the adult ranges, okay? Some different types of anemia. Like I said, iron deficiency anemia. Lead poisoning can cause anemia. Aplastic anemia, we are going to talk a little bit about aplastic anemia. It's kind of a big time shutdown of the bone marrow, okay? So it's kind of a across the board, we're not making any more bone marrow cells, etc. It's a bad news there. And then we'll talk about sickle cell anemia as well. We're not going to talk about thalassemia. You just don't see that very often in kids, so we're going to skip that one. All right, here's some doses for iron deficiency anemia. Iron deficiency anemia occurs, where you're going to see it the most is in that infant stage, like 6 to 18 months, 6 to 24 months, or you're going to see it in the adolescent. And those are the two time frames in a child's life where they use a lot of iron, or they need a lot of iron, okay? With the infant, you're going to see the maternal iron stores depleted about 6 months. So then you're going to need to supplement the iron with either formula or iron supplements at that point. And then when they get to the teenage years, they have an increased need for iron, but then they also, especially in females, have a lot of loss, with periods and things like that. So those are the two periods where you need more iron. Here's some foods if you're going to do some parent teaching, rich in iron. Those green leafy vegetables, kale, spinach, those are all iron, full of iron. Formulas that are iron fortified. Now, one thing iron can do, just know it can make babies constipated. So it's kind of a catch-22. They need their iron, but they also need to have dirty diapers. So if you have a patient or a mom that brings infant in and says, all of a sudden she's constipated, well, did you just start her on formula? Is it iron fortified? That could be the problem. Tuna, salmon, eggs, all things, iron fortified breakfast cereals, everything that has iron in it. All right, talk a little bit about lead poisoning. These are some of the things that you might see with lead poisoning. Some of the symptoms are, especially if it's just a tad bit of lead poisoning, you might see some just behavioral issues. A lot of times ADHD, they'll get a lead level, or if they suspect a child with ADHD or some learning problems, they'll get a lead level just to make sure that we're not having some lead poisoning, especially if they get a good history of, well, we live in an older house, we have lead-based paint, etc., etc. Higher levels, you're going to see the bad stuff, seizures, brain damage, and the higher levels of lead poisoning require chelation treatment. And chelation treatment is they introduce a binder that binds with the lead and it eliminates it from the body. That's bad too. I mean, not the treatment, but the higher levels of lead poisoning. These are the sources that you might, if you're getting a good social history, you might red flag or send up a red flag to you. Paint in the houses built before 1978. I don't know what's so magic about the 1978, but that's always been the way I've learned it. And that's the way we ask the question when I was out in primary care. When was your house built? If it was built before 1978, then we would draw a lead level. Lead levels are usually checked. We always checked them about 9 months anyway, just to check them. So glazed pottery, lead pipes, especially if there's some multicultural influences in the child's life, then you might want to think about lead poisoning as a source of anything that you see might be going on. All right, and again, I told you we were going to talk about sickle cell anemia. We're not going to talk about the thalassemia or the beta thalassemia, just because you don't see it very often. All right, sickle cell. You will see your share of sickle cell patients. Sickle cell presents usually, well, back up, it's part of the newborn screen. So, and a good family history is going to tell you the carrier traits and the genetics of it. So, you know, they may be looking for it just because there's a family history of it, or they may find it on the newborn screen and no one knew that there was a family history of it. So sickle cell disease usually presents like that. Now, sickle cell crisis will present with pain, most of the time it's pain related. Fever, sickle cell patients with fever, they come into the emergency department. They get treated a little bit differently in that we do a more robust workup because they do have a predisposition for infection, etc. Some labs that you might see drawn with sickle cell disease: hemoglobin, reticulocyte, or H&H, a CBC, a reticulocyte count. Those are the two big ones. If they're suspecting some sort of inflammatory process, they'll draw an ESR as well. All right, some clotting disorders we're going to talk about. We are going to focus on the factor deficiencies, the hemophilia A. We'll talk a little bit about HSP, Henoch-Scheinlein Purpura. The other, ITP, DIC, you can see those in children, but you'll be more likely to see them in adults. So we're going to eliminate those from our discussion. Okay, but ITP can present with, and other disease processes like HSP can present with some skin irregularities. So petechiae and purpura, you need to know the difference between petechiae and purpura. Petechiae, and we talked about this a little bit, I think in the gastro section, little tiny hemorrhages that occur on the body. Now, if they're on the face and the patient's been vomiting, that's not such a big deal. But if they're all over the body and they don't blanch, then you need to start thinking about, you know, could this be something bad? Purpura are bigger areas, okay? So they're big areas of petechiae. And when I'm saying big, I mean like, you know, like an inch. Those are big ones, okay? Those are purpura. HSP, Henoch-Scheinlein Purpura, you're going to see these areas in the dependent areas, like on the heels or in the back or on their back of their thighs. So wherever blood tends to pool, you'll see these areas, these purpuric areas. All right, some assessment things that you're going to look for with aplastic anemia. Family history is big, okay? Has your nose been bleeding? When you brush your teeth, do you have bleeding gums? Are you bruising easy? Are you tired? Those are all things that kind of go with aplastic anemia. Aplastic anemia can present a lot like leukemia, but not with the like the outward bleeding. The outward bleeding, like the nosebleeds and the gum bleeding, aplastic anemia, you're more likely to see that. Some treatments that you might see, okay? Blood product transfusion. You're going to give blood in a lot of different situations, so we're going to spend some time on that once we get to the chapter. Oxygen, IV hydration, those are a couple that you'll see with sickle cell. Primary goal in sickle cell is to hydrate and control their pain and give them some oxygen. Okay, those are the three biggies with sickle cell, and we'll talk about why here in just a few minutes. Lumbar puncture, bone marrow transplant. Those are things that you might see if you suspect a CNS involvement, central nervous system involvement with the particular type of cancer or leukemia or situation that's going on. If they suspect that it's moved over into the central nervous system, then they might do a lumbar puncture to test for those cells. Bone marrow biopsy, I don't think it's on that one. Bone marrow biopsy is what you're going to get if you're thinking leukemia. Okay, you may see some indication that it might possibly be leukemia on a CBC, but the definitive, is it leukemia, is it not, you've got to get some bone marrow. So a bone marrow biopsy is what you need to do. All right, some medications that you might see used. Iron supplements, especially if you have iron-deficiency anemia or just anemia in general. Factor replacement, that's with your hemophilia. Factor 8 or factor 9. Antibiotics. Okay, different cases you'd see antibiotics used in these kids. Kids with a cancer or with an oncologic situation going on, they're more prone to infection, so you might see some prophylactic antibiotic use. Sickle cell patients, you might see some prophylactic antibiotic use. Okay, chemotherapy, of course. The chapter focuses a lot on chemotherapy. We're going to briefly skirt the edge of chemotherapy. You do not need to know all of those medications in there. As far as the chemotherapeutic medications, it lists, I mean, it gives you a long list, so we're not going to go that deep. All right, this is a very interesting chart, and there's an expanded version in the text that I want to touch on. The differences between kids and adult cancers. In child, the biggest tissue type affected is the actual tissues. In the adult, it's the organs like the lungs, the prostate, the bowel, the bladder. Environmental factors in kids really are minimal in the increasing the risk, but strongly influenced in the adult. Very responsive to treatment. Children's cancers are, gosh, there's so many now that you can actually just cure. But adults are less responsive. But the chart in the book expands on that a little bit, and I just thought that was very interesting information. Some common types of childhood cancers. Leukemia is probably the most common. You have Hodgkin's disease, non-Hodgkin's lymphoma. Brain tumors are the most common solid tumor in a child. And there are several different types of brain tumors. There's a chart in the book that goes over that as well. And then other types of tumors, you have your neuroblastoma, your retinoblastoma. Neuroblastoma is seen more frequently in infants and younger toddlers. Osteosarcoma, Ewing sarcoma, those are bone cancers. Wilms tumor, that's a kidney cancer. One important thing, and I'll say this more than once, in a Wilms tumor, they're very vascular. So you don't want to mash on that belly. So if you suspect that there is a Wilms tumor, or you start to palpate that belly and you feel something over that kidney area, you stop and do not palpate that Wilms tumor, because it can actually seed those cancer cells throughout the bloodstream. So don't do it. Rhabdosarcoma, that's a soft tissue tumor, and then retinoblastoma is in the eye. One of the things you'll see with retinoblastoma, I don't know if you remember back for your assessment class, but when you look for a red reflex in the eye, you'll see a white reflex. So suspect retinoblastoma if you see that. All right, so let's go over to our chapter. All right, the first part of the chapter is always talk about variations in pediatric and adult A&P. This is the part that I want you to pay attention to in the pediatric, the iron stores. Okay, so mommy gives baby iron when she's in utero. Okay, but once they come out, then that starts to dwindle. So by about 4 to 6 months of age, that's gone. Iron supplementation needs to happen, okay? So make sure that your parents know that. That's a great teaching point. All right, and here's the expanded version of that chart. Just very interesting. All right, some common medical treatments that you're going to see with a child with either cancer or with a hematologic process. Here's my chart. All right, blood transfusion, like I said, you're going to give a lot of people a lot of blood. So these nursing implications over here, really, really important just to know. Not necessarily for, and you may see them on, this exam or the HESI or the pediatric part of the NCLEX, but just need to know this information for practice. Okay. What do we give blood transfusions for? We give them for severe anemia. We give them for hemorrhage. Traumas, we give a lot of blood. So just different reasons. But you need to know what to do if you suspect a reaction. Stem cell transplant. We'll talk a little bit about stem cell transplant. It's a 3-phase process. You've got and it's like from worst to best. They put a patient, and there's a whole section on this. They put the patient in the hospital. They treat them with high doses of chemo and maybe radiation, basically wipe out all of their immune system, bone marrow, everything, and then they put the good back in, and then the long-term support is the 3rd stage. So they make them really sick, and then they put some stuff in to get them better, and then they take care of them. And it can be done for a lot of different disease processes: leukemia, lymphoma, aplastic anemia. We had a friend of the family that had aplastic anemia, and she had a bone marrow transplant, and she's fine. It's probably been 15 or 20 years ago. So oxygen, can't ever go wrong with oxygen, right? Unless you have a congenital heart baby. You don't want to put oxygen on every congenital heart baby. Sickle cell, severe anemia. Think about it. These people don't have the hemoglobin to carry the oxygen, so they need some extra oxygen. A biopsy, it's how they go in and find out about solid tumors. Splenectomy, okay, if you have splenic sequestration in sickle cell, then they might have to remove your spleen. That makes you even more susceptible to infections. So just remember that part. Radiation, if they have a solid tumor and they're wanting to shrink it before surgery, or if they want to shrink it after surgery and they couldn't get it all, radiation may be an adjunct that they use for treatment for that, for solid tumors. Okay, so how, and this is kind of random that they put this right in the middle here, but a lot of times you're going to see a port or oil. All the time you're going to see some sort of central venous access. Ports are probably the most common. They can have CVCs, Broviac, catheters, different types of catheters as well, but most of the time you see a port. So this is what a port looks like. You have to access it with what's called a Huber needle. This is a sterile process, of course, and it's usually a checkoff in every one of your yearly competencies once you go out to be a nurse. So everybody needs to know how to access a port once you get out. Okay, once you get out, that's one of the things that they'll teach you. So, all right, so here goes the big long list of drugs. Okay, there are just a few on here that I want you to be familiar with. Iron supplements are one. Make sure you know the nursing implications of iron supplements, because you may be giving a lot of iron supplements. They can discolor your teeth. They can make your stool black. They can make you constipated. So those are all important things to know when you start to do some teaching. Factor replacement, factor 8, is what you use for hemophilia. If you have a patient that has hemophilia, that has had some trauma, presents to the hospital, you have to give them the factor 8, because what they're doing is they're bleeding in their joint, or they're bleeding in their brain, or So lots of teaching with hemophilia, which we'll touch on here in a minute, but factor 8 is what you give to stop that bleeding. Antibiotics, we talked about the different uses for antibiotics. Kids that are immunocompromised, if they're on chemotherapy and they're neutropenic, and we'll talk about what neutropenic means here in a minute, then antibiotics will probably be indicated. Antiemetics, Zofran is the big one right now. Once they get some chemo or radiation, they may have some nausea, vomiting, and that's what we use to treat that with. And then they go into all of the different, oh no, they do the biotherapy next. Biotherapy, if you have a patient that has low RBCs or low WBCs, they can get some injectable colony stimulating factors like Epigen or Neupogen that boosts the production of those particular types of white blood cells or red blood cells. All right, and then they go into the 1,000 different kinds of chemo. You do not need to know those. If you're going to go out and be a cancer nurse, then yes, you need to know those. But and I worked on the oncology floor for about 4 years when I first came out of school. I remember there were certain chemos that we gave, certain chemotherapeutic drugs that we gave a lot, and I was very familiar with those. So if you specialize in oncology, then you will get to know your chemo drugs. What you do need to know is kind of how chemo works. Chemo destroys the cancer cells, but it also destroys the good cells as well. So you end up with a patient that might not have enough white blood cells or might not have enough red blood cells, therefore oxygen carrying capability. Patient may not have enough platelets, be more prone to bleeding. So the teaching part of the chemotherapy at this point in your education is much more valuable than knowing what the chemotherapeutic drugs are or how they work. So that's what I want you to focus on. Okay. Radiation therapy. Radiation therapy, side effects of radiation therapy, mucositis, hair loss, burns to the skin. You need to know what to do about things like that. So comfort measures, no acidic drinks, no acidic foods. Those are real important with radiation therapy. And then moisturize, the areas that they are getting radiated if there's any kind of skin irritation or anything like that going on. Okay, I was looking for the chemo, the A and C. I thought it was right there, but it may be on down here. Okay, stem cell transplant. So we talked about the 3 stages. Okay, here are the 3 stages somewhere. Okay, maybe not. We will get to the 3 stages here in a second. 3 stages of the induction phase, which I said that's where they kill off all of the good cells, and then the actual administration of the stem cells, and then the recovery phase. Okay. All right, some assessment finding or some assessment parameters that you're going to look for if you suspect some sort of oncologic disease process going on. Bruising, bleeding, pain at point tenderness over a bone, any gait changes, any behavior changes, headache, big time health history dependent assessment. Okay, you need to, especially if you're suspecting like a leukemia, or if the patient presents with I'm bruising easy. Okay, that's kind of a hallmark. But if the patient has, if they're a toddler and they have bruising up and down their chin or their shins, or on their arms, or The places that they would normally have bruises, then I wouldn't be too concerned. But if they're ending up with weird bruises on their abdomen or different places that really wouldn't be prone to injury, then you might want to start thinking about that. Pallor of the skin, if they're pale, if they're tired. Of course, the petechiae. Make sure that you note all that. Okay, it goes through assessment findings. I'll let you read that. All right, here's your normal, again, this is in the PowerPoint, the normal, quote unquote, CBC values. And again, these are going to vary from facility to facility, so it's nice to know a range, but I wouldn't put these in your brain as forever memory. Okay. Here's your different types of white blood cells, okay? Bands and segs are going to be important here in a minute because we're going to talk about figuring an absolute neutrophil count, or an ANC. That's how you tell when a patient getting chemotherapy is immunocompromised, really to the point where you have to put some special precautions in place. So remember bands and remember segs. Eosinophils, EOS, is the allergic part. So if you have an allergy reaction, that part might be elevated. All right. Talks about bone marrow, and we talked about that. That is a definitive diagnostic tool for leukemia. Okay. Clotting studies is going to evaluate your clotting, and it's also going to be used when we're talking about platelets, thrombocytopenia, etc. CBC, we talked about that. It's going to tell us if we're anemic. It's going to tell us if there's some sort of infection. And again, based on the differential, what white blood cells are elevated, then that is either a viral infection or a bacterial infection. You don't need to know that information. CTs are looking for tumors. Iron, of course, looking for iron levels. Lead, looking for lead levels. A lumbar puncture, again, evaluating the central nervous system for metastasis. Reticulocyte count is pretty specific to sickle cell anemia. And then ultrasound, looking for kidney, abdominal tumors, etc. Oops, page doesn't want to load here. All right, so how do we take care of kids with cancer? Okay, lots and lots of teaching, lots and lots of coping, scary, scary situations. So you're going to have some really freaked out parents, okay? These are things to look for once we have been diagnosed that you need to teach your parents to look for, okay? Don't give the kiddo aspirin. Only time they ever get aspirin is if they have Kawasaki's disease, right? Or some sort of coronary issue. So remember that. It affects the platelets. All right, chemo. You do not need to know BSA. Okay. Here's what I was looking for earlier. Managing the adverse effects of chemotherapy. All right, these babies might lose their hair, so self-esteem might be an issue, especially if they're an older child. Okay. They may even lose a limb. Teenagers, osteosarcoma, amputation is a lot of times the way that they treat the cancer. So, lots of body image issues. So here we go back with the psychosocial things again. Nausea and vomiting, of course, can be medically managed. Kids not wanting to eat can be a big issue too, whether they're nauseated, vomiting, or if the inside of their mouth is just so torn up by the radiation, the mucositis, that they don't want to eat. So whatever they want to eat, they get to eat. All right. No special diets here. Ice cream for breakfast is fine. All right, so preventing infection with kids. Meticulous hygiene. That's why they have these kids on the separate floor. The bone marrow transplant unit is a lockdown wind tunnel. If anybody spent any time up there for their clinicals, then it is a super high infection control area. Okay. All right, here's the ANC. Okay, and I do want to talk a little bit about this. I want you to be able to figure an ANC. Okay, so what you're going to see, if you're going to be given a value, you're going to add the bands and the segs. Okay, and then multiply that as above, and it gives you an example there. And that's going to be your ANC. Okay, the total number of neutrophils present. If it is below 500, okay, and that's the typical policy. If it's below 500, then they are on what's called neutropenic precautions. And here are your neutropenic precautions. Okay, so I want you to know these. If you hear a patient is on neutropenic precautions, this is what you see. All right. In addition to that, you're going to want to make sure that they don't have any razors. They shave with an electric razor if they're shaving age. Anything, you clean their room up. You make sure there's no trip hazards because their platelets could be down too. So you want to make sure that you clear the area and you don't, have any hazards that might make them bleed. Okay. Alrighty. Oh, here's our phases. Pre-transplant. Okay. This is the prep. Their own cells are killed. Their total body irradiation, and big high-dose chemotherapy. They're put in those rooms, those special rooms back there that are like positive pressure rooms. And they're in full isolation because they have no immune system. Then they get their donor cells at the very end of that. During the post-transplant phase, you want to look for graft versus host disease, and this is what you might see. Some diarrhea, sometimes some vomiting, and then this little rash right here. So a good skin assessment is very important. And then afterwards, support. They usually see the oncologist very frequently, and then they work with child life and social work just to kind of promote a normal life, and most of the time it's successful. All right, this talks a little bit about care for the dying child. We're going to talk about that next week, so we'll skip over that point. Some oncologic emergencies, the biggest thing is sepsis. Okay, if they're neutropenic and an infection is introduced, then they can get septic really quick because they have no immune system to fight it off. So go make sure you know the sepsis, what you're looking for there. All right, so let's talk about iron deficiency anemia and sickle cell anemia. Iron deficiency anemia just happens when the body doesn't have enough iron to produce hemoglobin. So you're going to see fatigue, you're going to see weakness, you're going to see pale skin. Those are the things that you see with anemia. Iron deficiency anemia is really, you see it a lot in infants because of milk, cow's milk. Cow's milk doesn't have a very high iron content, and you can have some little microcytic bleeds in your stomach if you introduce cow's milk too soon, which can further cause loss of blood. So that's why you see it in kids. In teenagers, again, they need more iron. And they get less iron. Their dietary intake of iron is probably not very good. So those are the two age groups where you're going to see some anemia. Real important to get a good health history if you suspect anemia. A CBC will show you your anemia. And again, those red blood cell indices are going to tell you what types of anemia that you're dealing with. But again, just focus on iron deficiency anemia for this exam. What you're going to see, what it's going to look like, in addition to being tired and sleepy, you need to look at the skin. Okay, you're going to see like when you pull down their eyes and look, it's going to be real pale. in their eyes, in the inside of their mouth, going to be real pale. You might see some spooning of the nails, and there's a really good picture of nail spooning with Iron-Deficiency Anemia there. All right, so promoting safety with these kids are going to be tired and clumsy, and so you want to make sure that you keep them safe. They get dizzy when they stand up, so tell them to stand up really slowly until you can get their iron levels back where they need to be. Iron supplements is the way that you're going to fix this. All right, with lead poisoning, again, lead poisoning can happen from ingestion from glaze or from paint. You know, that age group, kids put everything in their mouth. So if you have a house that's built before 1978 and they have lead paint, that could get ingested. Labs, we draw a lead level, and then if it's too high, they can do some chelation therapy if they need to. Most of the time, it's just get rid of the risk, get rid of the source. Okay, aplastic anemia. We talked a little bit about that. It is an across-the-board wipeout of the bone marrow, okay? So pancytopenia is what it's called, decreased number of all of the blood cells, okay? As you can see, it's pretty, I mean, it puts you at risk for a lot of things, for bleeding, for infection, for anemia itself. So the treatment for that, most of the time, is a stem cell transplant. Okay, sickle cell disease. Sickle cell, like I said, is usually detected on the newborn screen. Treatment, or the presentation, usually is pain, shortness of breath. Occasionally you'll see like an altered mental status, and you have to think about stroke when you see a patient with sickle cell that presents with altered mental status, because those cells, what happens is they get weird shaped and they clog up the vessels. Well, that's just kind of the same thing as a clot, okay? If you have one of those going on in your brain, the occluded area, then you could actually, you know, have a stroke with this disease process. Pain, you see a lot of leg pain, back pain. Big three things: infection control, hydration, oxygenation. Oh, wait. Pain control, hydration, infection control, and then always put them on some oxygen. Okay, so I want you to read through this section on sickle cell. Pretty important because you'll see it a lot. Okay, no acute presentation versus what you're going to see chronically with these children. All right, it's a very important section. There's some pain control. These kids usually need like morphine to take care of their pain, and it's not a little dose of morphine. And this is where, when you figure safe dose of morphine, you may be outside your safe range. And with a child like that, always check with your physician and double check if you see a dose that's outside the safe range. But the majority of the time, it's going to be a little bit higher than normal, just because they have such a history of pain management, or pain management with medication. Okay. It talks about stroke, very important, nursing assessment, looking at the spleen. Okay, then it goes into thalassemia, and again, we're not going to cover thalassemia or G6PD deficiency. So you get a pass on that. I do want to talk briefly about hemophilia and HSP. Hemoglobinopathies purpura. Idiopathic, usually it's a vasculitis in kids that presents sometimes after some sort of viral illness. If it is, most of the time it kind of goes away on its own, it's self-limiting. But if it is bad enough, a lot of times they get effusions in their joints where they can't walk. Then they may do some steroids to kind of suppress that reaction. It's a very strange disease. They usually present with those purpuric lesions on dependent areas, like the feet, like the buttocks, the back, and then they have some joint pain. That's what purpura look like, bigger areas of petechiae. Okay, let's talk about hemophilia. Hemophilia is a lifelong disorder. It's a lack of a clotting factor. There are varying different types of hemophilia. There's hemophilia A, there's hemophilia B, there's von Willebrand's. They're all some sort of factor deficiency. The most common thing you're going to see is hemophilia A, and it's a factor VIII deficiency. So what happens with these kids? Lots of safety issues. They don't play contact sports. You have to be very careful. Even when they're just walking, if they fall and hit their knee, they can have a huge, effusion in their knee. If they fall and hit their head, they could have a bleed in their head because they don't have that clotting factor. Just a tiniest of injury can lead to, bleeding that won't stop. So once parents see that, a lot of times they have the factor that they can administer, but if they have something bigger, they're going to end up in the emergency department getting factor VIII or whatever factor they're deficient in. Okay, so as you can imagine, there are lots of safety concerns with a child with hemophilia. There's a big knee. Okay, and then here is a very brief teaching guideline to prevent bleeding in the child with hemophilia. You can think of probably 20 more things to put on there. Okay, von Willebrand is just another clotting factor or a factor deficiency. Basic treatment is the same as with hemophilia. All right, and I think the last thing we're going to talk about are leukemias or in cancers. Leukemia is probably the most common cancer you're going to see in kids. It has a couple of acute types of leukemia and a couple of chronic types of leukemia. ALL is the most common. ALL, it happens in younger kids. It says age 2 to 10. AML usually is found in the older population, the adolescent population. And it just depends on what cells are affected. Okay. They present the same. Again, with a systems focus, you're going to say, what do these kids look like when they come in? They're going to be tired, they're going to be pale, they're going to bruise easy, they may bleed easy, they may have recurrent fevers because their white blood cells aren't working. Okay, here's the pathophysiology. You can read through that. You don't need to know the stages of leukemia treatment. You do need to know what they're treated with. Okay, usually chemotherapy, sometimes radiation. Okay, here's the things that you want to look for on an assessment: fever, pallor, headache, nausea, vomiting, bleeding easy, bruising easy. Right, AML, like I said, is usually in the older kiddos. And long-time survival for these is pretty good. I think it's about 80% in ALL, 50% here in AML. All right, the lymphomas, again, just depends on the cells that are affected. So a couple of different lymphomas that you'll see, Hodgkin's and non-Hodgkin's. Hodgkin's tends to affect the lymph glands that are closer to the surface of the body, and then non-Hodgkin's are the deeper lymph nodes. Did I say lymph glands? I think I did. Lymph nodes is what I meant. All right, these are going to present pretty much the same. Tired, weight loss, night sweats, just not wanting to eat, weight loss, sometimes a viral infection a few weeks before, so a good history of present illness would be important. Okay. Nursing management, these kids are going to get chemo or radiation, so nursing management just has to deal with that. Side effects of chemotherapy. Okay. Look for their ANCs. Prevent infection. Watch their skin. Treat the nausea and vomiting. Okay. Weight loss, anorexia, make them or provide them with foods that they like. Okay. Talks about non-Hodgkin's lymphoma. Now this chapter doesn't have a good comparison between Hodgkin's and non-Hodgkin's. I'm going to see if I can find one of those external and put that up for you. I think those are always helpful to me. Brain tumors are the most common solid tumor that you're going to see in kids. This does give you a list of a few kinds of brain tumors that you might see. These kids present with sometimes headache, nausea, vomiting, gait disturbances. Papilledema is a assessment finding that you may not see, but the physician may see when they look in their pupils. The vessels in the back of their eyes are very engorged, so that can be a sign symptom of a brain tumor. Okay, but most of the time it's a physical milestone change. They're stumbling, they fall, they have headaches, some sort of physical increased intracranial pressure symptom. All right, tumor management. They sometimes radiate, they sometimes do surgery, they sometimes do both. It depends on what type of tumor it is and where it's located. Okay. Here's the things that you want to look for on a health history. Real important. Nausea, vomiting, headache, blurred or double vision. I didn't mention that one, but that is a good one. Seizures, of course. If they have a first-time seizure and then have any of these other symptoms, they usually get a CAT scan of the brain just to see what's going on. Okay, I'm going to let you read through this. Neuroblastomas. Neuroblastomas you're going to see in younger kids. Infants, it says less than 12 months of age. Unfortunately, there are neuroblastomas that we discover in those kids. It's the most common extracranial solid tumor. Okay, so outside of the brain, neuroblastomas are the most common. And again, you don't need to know staging. They find these usually by CAT scan. All right, bone and soft tissue tumors you see more so in the teenage. You hear about it in the adolescent age group. Soft tissue tumors in younger kids, bone tumors in the adolescents. Okay, soft tissue tumors are things like rhabdosarcomas, bone cancers, osteosarcoma, Ewing sarcoma. Most of the time these present as pain. Okay, osteosarcoma, long bones, humerus, tibia, femur. Lots of osteosarcoma in the femur. And like I said before, sometimes the treatment for this is amputation. So you end up with lots of body image issues. Okay. Sometimes they do chemo and radiation before they do surgery to try to shrink the tumor down a little bit. Of course, they do limb sparing surgeries. They save as much of the limb if they have to go the route of amputation as they can. And then after surgery, prosthesis, gait training, rehab, that's all an important part of it. Ewing's sarcoma is more like the pelvis, the chest wall, the ribs, and then if you're going to see it in a bone, it's going to be in the middle of a bone. So different placement than an osteosarcoma. Treatment, again, pretty much the same. Rhabdo, like I said, soft tissue tumors, neck, extremities in the muscle or the, not in the bone. So these are normally seen in younger kids. Chemotherapy, surgical removal, sometimes if they can get if they can make sure that it's contained enough to get in there and think that they got everything, it just depends on the site. Chemotherapy most always. All right. Oh, one last thing, Wilms tumor. We did talk a little bit about Wilms tumor, never palpate a Wilms tumor. Renal tumors, most common renal tumor. You don't need the note to know like the order, like this is the 4th most common solid tumor. You don't need to know that. But the one thing that I want you to know about a Wilms tumor, never palpate a Wilms tumor. Retinoblastoma is, again, the eye, cancer of the eye, and it's the tissue of the eye, and you see the white reflex, not the red reflex. I've seen one of those actually. All right, we're not going to talk about reproductive cancers, but I do want you to look at, of course, the care plan. Okay, lots of good teaching points there. Kids with cancer have a lot of psychosocial issues, so you're going to be doing a lot of support if you work in this area. A lot of people get very sad when they think about kids with cancer. However, it's probably one of the most positive places I think I've ever been is the Hematology Oncology Clinic. So, sorry, I didn't mean to click out there to Facebook. All right, that's all I've got. Y'all have a good day.